in psychiatry. I might keep my camera off just because I'm just having reception challenges. And let me pull up the presentation. There we go. And gonna talk about opioid use disorders and pain today. Let me start the slideshow. As I begin, and Rana, can you see the slides? Okay, great.
Yes, we can.
Okay, great. So as we begin, no financial arrangements, no disclosures to make related to contents of this activity. Of course, other than the fact that this entire ECHO is being funded by AHRQ, Agency for Healthcare Research and Quality. So we're gonna talk, I really kind of wanna start by talking briefly about the comorbidity of opioid use disorders and pain, right? And then really go into how do we manage pain, just the basics of managing pain in individuals who might be maintained on buprenorphine or naltrexone or methadone in the setting of pain, both acute and also chronic. And that's really what we want to do today. So I'll start with just a little bit of data on prevalence, right? How common is pain in individuals with opioid use disorders? So I've cited a few studies here over the years, starting from 2003 all the way up until 2017. And you can see that certainly in the newer studies, there were two studies that came out in 2017. And you see that over half to almost 2/3 of individuals with opioid use disorders also meet criteria for chronic pain. So quite significant, right? So the take home point for this slide really that I want to convey is that if you're working with individuals, right? So a few of you mentioned that you work with patients with opioid use disorders. We really ought to be asking about and screening for any chronic pain and vice versa, right? So I'm going to go a little bit deeper into this study by Eling Sayre done in 2017, right? So here's what they found. It's actually quite a good study, elegant study that tracked all adults who entered treatment for opioid use disorders at their clinic over a 10-year period, right, from 2006 to 2015. And it was over 5,000 individuals, right? So you can tell it's a pretty busy clinic. It's a big clinic. Over 5,000 individuals entered treatment over that period. And out of those, about 35% had no pain at any point. About 10%, just under 10%, when they entered, had opioid use disorders and subsequently at some point developed chronic pain. Another 15% had opioid use disorders and pain at presentation. But for almost 40%, it was the pain that came first, right? Chronic pain seemed to precede the development of opioid use disorder. And maybe that speaks to, sort of the changing demographic and everything that we often talk about, liberal prescribing of opioid medications, maybe overprescribing of those medications, responsible prescribing, etc. But for almost 40%, it seemed to be the chronic pain that came first. And then opioid use disorder developed subsequently. And perhaps unsurprisingly, patients who had chronic pain initially, before developing opioid use disorder, tended to have high rates of mental illnesses, other health conditions, and those, the 10% that started with opioid use disorder before development of pain, essentially had more severe substance use disorders. They often had other substance use disorders, and they also had things like, were more likely to have things like HIV and hepatitis C. So maybe these are somewhat different patient populations. But the point remains that we really must understand how to manage pain in both of these populations. So I'm going to start first with acute pain management, sort of basic principles of acute pain management. Caveat here, right? This is a half-hour presentation. So, I think just last month, I actually did like a full 1-hour talk on this, right? We can go into a lot more detail, but the goal here for me today is to really give you the basics, right? And provide an overview. So starting with acute pain management, and I started with some art, public domain art done by individuals suffering from pain. And I thought it's poignant. So I will begin with a vignette. I've changed all potentially identifying information, but this is really based upon someone I saw when I was an addiction psychiatry fellow about 11 years ago. So AN is a 45-year-old female, status post a shoulder surgery. She has a history of opioid use disorder and was previously treated with methadone on 2 occasions. And both times she eventually stopped methadone and returned to using illicit opioids, right? And right before the surgery, she had been using heroin about half a gram 2 to 3 times a day, smoked, not injecting it. And now post-operatively, she is maintained on morphine continuous infusion at 4.2 milligrams per hour, plus 10 milligrams IV every 4 hours as needed for breakthrough pain. And she last used it 2 hours ago, so she's not due for it again for 2 more hours. But she is requesting more pain medication. She reports her pain is 9 out of 10. She is crying, she's in tears, but vital signs are stable. I was the consultant, and as I get to the floor, I'm told she is drug seeking. She's already getting more pain meds than any other patient on the unit. She doesn't need more. Besides, she's an addict, and we don't want to worsen her addiction, right? So you keep that in mind. Let's keep this vignette as we go through the next several slides. So some commonly held beliefs from what we know from literature. So even in general, acute pain, particularly perioperative pain on inpatient basis, is frequently undertreated, up to 60% in inpatient settings. And we don't have great data on it, but it makes sense. And many experts have suggested that acute pain, perioperative pain in individuals with opioid use disorders is even more likely to be undertreated, right? And we know that healthcare professionals tend to view addiction as primarily a social problem, and those attitudes have persisted, right? Patients are often seen as manipulative by healthcare providers, according to this study by Van Bokel, who did a nice review about 7-8 years ago. So suggested approach, right? So first of all, start with a point of trust. Accept the patient's self-reported pain. And keep in mind that pain behaviors vary widely. They may vary, for example, based upon a person's background, right? Cultural background. And vital signs are not very reliable indicator of pain intensity. Certainly we take them into consideration, but by themselves, they're not extremely reliable. Consider addiction, right? Which is a substance use disorder where we often see things like loss of control, compulsive use, consequences, cravings, versus pseudo addiction, which is the idea that emerged back in the 1980s, really meaning that a person is requesting more pain medications or acting in a way that might suggest addiction, but because we're under-treating their pain. And in fact, if in the case of pseudo addiction, if we go up on the pain medication regimen, right, you would see some of those behaviors go away and functioning improve. By contrast, if it's a true addiction, a substance use disorder, simply raising the dose of a medication is not going to improve functioning. And the functioning may actually continue to tank and deteriorate, right? And also consider physiologic dependence, which is when a person's body has simply become used to a particular medicine, right? And if it stops suddenly, they will experience withdrawals. Does not just happen with opioids, happens with many medications. For example, stimulant laxatives come to mind, right? And if required, do not withhold opioid analgesics from people with addictions. In the case of acute pain, the data, there isn't really data showing that acute pain management will actually worsen addiction. The concept is very different when we talk about chronic pain, but remember, right now we're focusing on acute pain. Also keep in mind that if someone already has an underlying opioid use disorder, they're going to have high degree of tolerance, and just like the patient in the vignette, may actually need higher doses of opioids than other patients. And also remember that opioid agonist treatment will treat the baseline addiction, but not acute pain. And this is a consult we get every now and again, where someone calls us up on the PALS line, saying we have so-and-so patient on the inpatient unit. They're going to such and such methadone clinic and they're receiving 80 milligrams a day of methadone or 90 milligrams a day of methadone. That's such a high dose. Do they need additional pain management? And the answer is they very well may, because that dose of methadone is their baseline dose and is not going to provide any acute analgesia. So now a slide on methadone in acute pain management, then we'll go into buprenorphine and naltrexone, are 3 FDA approved medications for opioid use disorder. So these are the suggested practices. If you're working in an acute care setting, for example, and a patient comes in and the patient is maintained on methadone. So first, every patient will have a home clinic, an opioid treatment program they go to receive their methadone, right? Usually multiple times a week. You can continue the baseline methadone after verifying the dose from the home clinic. Patients will readily tell you, because patients are worried about not receiving their methadone going into withdrawals. So once they tell you, if they're able to give that information, call the home clinic, continue it. If the dose cannot be verified, right, it's safer to break up the self-reported dose in 3 to 4 times a day dosing rather than giving it all at once, right? It reduces the chances of a single dose toxicity. And secondly, methadone, when split up into 3 or 4 times a day dosing, is actually more effective for pain. So it serves two purposes. And you can add in other short-acting opioids on top of methadone for breakthrough pain, right? It will provide additional analgesia, and that is the recommended strategy. You may also gradually increase methadone dose. Don't administer buprenorphine. This comes up sometimes, but if a patient is maintained on methadone and you give them buprenorphine for analgesia, it will precipitate pretty significant withdrawals. And patients who may not be able to take their oral dose of methadone may be given IV methadone. But generally, of course, you do a dose reduction, right? At least 1/2 up to 2/3, and you're generally gonna then further divide that dose up into Q6 or Q8 hour regimen. Remember, and that's the key point, methadone for analgesia requires multiple times a day dosing, whereas methadone for treatment of opioid use disorders is once a day dosing and can only be done through an opioid treatment program. Next, let's go into buprenorphine in acute pain management, right? So the idea is, and this is the same idea actually for methadone as well, right? That for acute pain, the responsible pain management principles tell us that before resorting to opioids, we want to employ all of our non-opioid modalities. And there are many of them, and they're always growing, right? And they can include, right, conservative management like rest, ice, compression, elevation, but also things like epidurals, right? Oftentimes people will do an epidural, run a local anesthetic through it. Nerve blocks, even emergency department doctors that I work with are getting increasingly experienced at doing nerve blocks in an acute care setting, right? Ketamine, alpha 2 agonists such as clonidine or Presidex, which is a parenteral agent, are all very good medications and can be used safely with buprenorphine. But now let's look at what can we do with the buprenorphine itself in the case of acute pain. So first, adjust the dosing interval. Just like methadone, you want to dose it more frequently. So if someone at baseline is receiving 12 milligrams a day, for example, you may temporarily split it up into 4 milligrams 3 times a day. Same dose, but it's going to lead to more analgesia. You may also, and very often we do this, temporarily go up on the dose of buprenorphine. So for example, if someone is at baseline 8 milligrams twice a day, temporarily go up to 8 3 times a day, and then augment with non-opioid analgesics such as acetaminophen or ibuprofen. In an inpatient setting, in an emergency department setting, consider IV buprenorphine. A little cocktail party trivia: the first documented use of buprenorphine in the United States was actually in an emergency department to treat acute pain related to a myocardial infarction way back in I believe, the early 70s. So we will come a full circle, where we're once again using buprenorphine often for pain management. Augment with short-acting opioids that will be able to overcome the mu receptor blockade provided by buprenorphine, right? And often these include things like fentanyl as well as Dilaudid. And our anesthesia colleagues are very experienced at using these modalities, and consult an addiction medicine expert. If needed, if it's an outpatient setting, certainly bring the case to us. What about perioperative management? Say you have a patient on buprenorphine who's about to have an operation, a surgery. So in general, keep in mind that there is a big gulf that exists. We know that our patients fear mistreatment and providers fear deception. So as outpatient providers, it's our job to advocate and hopefully bridge the gap. There is also a lack of consensus in the field. Depending on which educational center or which hospital you're looking at, there might be differing levels of experience in terms of managing perioperative pain on patients maintained on buprenorphine. So I think oftentimes what we do is critically, preoperatively, if it's an elective surgery, as soon as we know a surgery is happening, we want to get consent, start talking to the primary care providers, the anesthesiologist, if possible, the surgeon, to come up with a game plan, right? In general, at this point in 2021, for most surgeries, the recommendation is that buprenorphine should not be discontinued before the surgery. We used to do that routinely. We've increasingly moved away from that practice. Many clinicians may lower the dose of the buprenorphine to about 8 to 16 milligrams per day in divided doses during the perioperative period, but we generally can continue it. The current evidence, to reiterate, does not support the practice of routinely discontinuing buprenorphine before the surgery. Buprenorphine is a powerful analgesic and can be combined synergistically with other opioids as well as many other non-opioid kind of multimodal analgesia, right? So we generally just continue the buprenorphine, and this was an editorial. A lot of this work has been done by Dr. Anna Lemke out of Stanford University, and this was one of the editorials where she really, recommended that, and increasingly the data supports this practice over the last 2-3 years. Finally, naltrexone. If you have a patient maintained on naltrexone, remember naltrexone is a very powerful mu-opioid antagonist, right? So in general, I tell all my patients with naltrexone who are on naltrexone to carry a medical alert card that informs first responders that they are on naltrexone, right? Again, for acute pain, in general, the name of the game is going to be multimodal analgesia, including things like regional analgesia, conscious sedation, right? Or even general anesthesia, right? If it's an elective surgery, then we generally recommend that if someone's been taking an injectable long-acting naltrexone, I tell them to take their last dose of the injectable naltrexone 4 weeks before the surgery. If they've been taking the oral naltrexone, which I actually don't recommend for people with opioid use disorder, evidence does not support it. But say you have a patient with alcohol use disorder who's taking a daily oral tablet of naltrexone, you generally tell them to take their last dose 72 hours before the elective surgery, right? This is again just a little algorithm. Someone on methadone, acute pain management, right? They're especially in an inpatient setting. You're gonna confirm the dose, continue it, and you may divide it and augment with short-acting opioids as needed, right? With buprenorphine, historically, what we used to do is stop the buprenorphine, start full agonists, right? And then later on go back to buprenorphine. But increasingly, we're taking that second strategy where we just continue the buprenorphine and use that as sort of the centerpiece of the pain management plan. Next, looking at we have about 7 minutes left, gonna go into chronic pain management, right? And this is again another piece of art which I thought was, kind of captures maybe the experience of many of our patients who live on a daily basis with chronic pain, which can be a very disabling condition. Some basic conditions. So approach, as you see, is going to be very different with chronic pain as opposed to acute pain. Here with chronic pain, remember that a prior history of opioid use disorders is the single biggest predictor of aberrant behaviors to prescribed opioids. So we want to really avoid using opioids in this population if we can do it. And so we want to cast a wide net, use a multidisciplinary team approach, consider consulting a pain management specialist, and don't forget about using all of our non-opioid pharmacotherapy, and there are many of them, right? NSAIDs, SNRIs, tricyclic antidepressants, membrane stabilizing agents, right? Topicals, gabapentin, pregabalin, but also our evidence-based non-pharmacological therapies, including things like cognitive behavioral therapy for pain, acceptance and commitment therapy, right? Physical therapy, pain self-management, yoga, meditation, pool therapy, acupuncture, traditional healing, right? As well as our interventions such as nerve blocks, TENS unit, in some cases, spinal cord stimulators, etc. So cast a wide net, seek consultations, and really avoid using opioids if possible, right? Responsible opioid prescribing has several factors, and we do a whole talk on this as part of our ECHO, including being aware of individual risk factors, using screening tools, monitoring for aberrant behaviors, right? Using urine drug screens, prescription drug monitoring, treatment agreements, and always prescribing naloxone to patients who might be receiving opioids or may have opioid use disorder, right? Now, kind of gonna go through a little bit the time, in the interest of time, right? Gonna do a little bit about methadone and buprenorphine for patients with chronic pain. Again, this is based on a real patient. This was a 64-year-old female who came to the emergency department with dysuria, who was actually found to have advanced cervical carcinoma with local metastasis. And it was identified that she was going to need a lot of pain management, right? The doctors anticipated a great need for pain management. But there was concern because she had a 30-year history of heroin addiction, right? So we coordinated very closely. She sought treatment at our clinic. We started her on methadone because we felt that her pain management need was so great that buprenorphine would not do the trick. So we placed her on methadone. We carefully titrated it up, while her oncologists and palliative care physicians placed her on additional short-acting opioids for breakthrough pain. And we just coordinated, and she actually did very well for about 3 years until the end of her life. And she was quite happy with her pain management, and felt she had the dignity at the end stage of her life, right? So basically, in some cases, patients' opioid dependence, right, the need for pain management may be so great. In such cases, for example, end stage pain, cancer-related pain are the two main situations that come to mind, where methadone maintenance may be the answer, right? Because it's going to allow us to augment it using other analgesics, other opioid analgesics, to really achieve optimal analgesia. But for most other patients with chronic pain and opioid use disorders, I think buprenorphine is the way to go. It's a great pain medication, right? It's a great analgesic. Another vignette, a 55-year-old female presented for addictions treatment, had a 12-year history of chronic pain following an ATV accident and pelvic fracture. And she had built up over the years to doses of opioids up to 300 morphine milligram equivalents a day, and there were aberrant behaviors. She was running out early, buying them off the street, going to multiple doctors. She was reporting problems in marriage, work, relationships. She had worsening depression, worsening anxiety, and really importantly, she said none of this was helping her pain. She said, in fact, I now have pain all over and it's worse than ever. So we diagnosed her not just with opioid use disorders and chronic pain, but also with opioid-induced hyperalgesia, right? And to treat all of that together, we placed her on buprenorphine and actually did really well on a dose of 4 milligrams 3 times a day. Reported improvements in pain, was happier, functioning better at work. And she said, quote, I have my life back, right? So, very often for this population of patients with chronic pain as well as opioid use disorder, or patients with chronic pain who may have developed opioid-induced hyperalgesia, think about using buprenorphine. And keep in mind that for this cohort, this group of people, you really want to dose the buprenorphine more frequently, into 3 times a day or even 4 times a day dosing. But if you do that, you can really achieve good outcomes, right? This is just a reference slide. Many reasons why buprenorphine may actually be a great option as a frontline analgesic, right? It's got a very favorable safety profile. It's safe in renal failure, right? It's safe in patients with hepatic dysfunction, and it actually is a strong analgesic. This was a study from about 6 years ago. And I'll end with this study. And this was done at a pain clinic. And what they did was they took their patients with chronic pain who were on very, very high morphine milligram equivalents, right? Everyone was on 200 morphine milligram equivalents or higher. And many of them were actually on over 1,000 morphine milligram equivalents a day. So very high doses, often on multiple opioids, right? And what the authors did is that they took all of these other opioids and instead converted them to buprenorphine monotherapy. And 3 months after that conversion, they checked in and said, how is your pain, right? And this is just a visual analog scale, 1 to 10. The higher the number, the worse the pain. So you can see that for all of these patients, even the ones at the highest MMEs, the pain significantly decreased 3 months after they were converted over to buprenorphine, right? This was significant clinically and statistically, and certainly a whole lot safer, right? So I think, something to keep in mind. One note, sublingual forms, which we often use for treating opioid use disorders, are not approved for treatment of chronic pain, but can be very effective and are in fact commonly used. Buprenorphine patch, right, as well as a buccal formulation called Belbuca, are approved for treatment of chronic pain severe enough to require daily around-the-clock opioid treatment, but they generally come in lower doses. So very often we do wind up using sublingual buprenorphine. Finally, If someone has chronic pain that is significant enough to require opioid analgesia, of course, we should avoid naltrexone, right? And instead consider using buprenorphine or, in rare cases, methadone. These are some references. We're exactly at 12:30, so I am going to stop here. I do